Okay, so here we go. Assalamu alaikum. Welcome everyone on board. So today's quick review or the new series which I have just started. We have discussed the basics of chalking out any case scenario based question. Okay, and the second in the second discussion we did some neuro anesthesia yesterday. So today we will be thinking what are the challenges and what are, because pediatric anesthesia is a big specialty, even subspecialty of anesthesia. With reference to exam and with reference to practical conduct of an pediatric anesthesia, we will just try to chalk out some of the important points which all of you needs to know. Okay, so you can say that a pediatric patient is a small adult. Okay, so this is one thing. So all the things which you are usually doing, you will find it totally different in pediatric with reference to equipment. Like there will be different equipment, different drug preparations. Okay, not really the drug doses. It will be weight based. Usually, some because of more of surface area as compared to body weight. Okay, uh, and more of fluid, body fluid. Okay, or altered fluid dynamics. Actually, sometimes dose requirement may be more than adults. Okay, so this is one thing you should be knowing. But because of altered metabolism, the further doses will be decreased. Like initial doses may be more, but the subsequent maintenance doses will be decreased because of not fully mature metabolism and excretion from liver and kidney. So this is the important thing. So that's why I'm highlighting the drug preparations and IV, like this IV syringes. Okay, so usually, preferably, you should not use big syringes in pediatric patient. Not only it can cause air embolism, but it can also cause extravasation because of high pressure. Because force pressure is force per unit area. So if you have bigger syringes with smaller cannulas, it will create more pressure and it can create more problems. So it is always advisable to dilute medications and give them accordingly. Okay, so equipment, all the equipment, whether it is an laryngoscope, whether it is endotracheal tubes, LMAs, like all the anesthesia equipment which you are using will be of different category and different sizes, and you have to carefully, you should be knowing how to calculate the endotracheal tube size, how to calculate the LMA size, how to calculate the cannula. Usually cannula will be either you might be using 26 or 24 in majority cases, and at least in neonates, and 22 in relatively bigger children. Okay, so this is with reference to the challenges that you then. Another with the same points, I will just tell that IV cannulation is a big challenge. Okay, so IV cannulation is a big challenge, and you will face a lot of problem. So the possible uh, solutions will be either amla cream. This is one thing. Other will be vein visualizer, then inhalational induction, and then taking IV cannulas, then preoperative. This is also a challenging thing, how to communicate with the baby. It is very difficult to build up a rapport. Okay, so preoperative enzylysis and as well as IV cannulation. It's actually knitted together. Okay, and you have to. It will be a challenging thing. Sometimes you can have some oral intranasal medications like dexmedetomidine, fentanyl, and midazolam, intramuscular ketamine, oral midazolam with ketamine along with paracetamol. These are different techniques which you can use to get the patient sedated before shifting to the OR. There are certain more things like in preoperative and assessment in some developed countries, there are also availability of mock operation rooms, so that the baby, the child will be familiar to the OR. Okay, so these are different things to develop, not only with the build of the repo, and also there will be some things which will be helping the IV cannulation. So amla cream is one of them, vein visualizer, inhalational induction, intramuscular pre-op this anxiolysis, as well as sedation. Okay, so you can use Presidex, dexmedetomidine, intranasal, uh, midazolam, ketamine, as I have mentioned. Okay, amla cream is also useful because it can anesthetize that area, but it's still the baby will cry. Even if there is no pain when you are holding the hand, it will create a problem. But still, you can use in some like relatively older children, you can use this technique. Okay. So this is one of so we have discussed two, three important points up till now. Then another important thing is the preoperative assessment. Okay, preoperative assessment, especially because baby cannot tell, so you have to have good communication with the parents or whatever legal guardian the patient have. This is also with reference to not only with the proper consent. There are so many consent issues, and they in international exams you will find a lot of questions with reference to consent. Of course, today is not our domain to discuss too many details. I'm just giving you a bird eye view. What are the challenges and what are the things you should be knowing with reference to pediatric anesthesia, and our because our aim is to answer the question when it is asked with the pediatric. Like we got you, no exam will be finished without a pediatric question. So that pediatric question the common things you need to. So whatever I'm telling you, you can make your own very concise sentence in which you will tell the important things. Okay, so the one of the most important thing, the sentence which you have to say is altered physiological, pharmacological, and anatomical considerations leading to challenging anesthesia conduct. This sentence should be with you all the time. Challenging anesthesia conduct. Okay, so this is we are discussing what are the challenges with reference to practical conduct of anesthesia, as well as evaluation of the patient, as well as how to use perform actual anesthesia. Okay, so as I told you, with reference to preoperative assessment, the important thing which you should be focusing is number one, if preoperative fasting. Okay, preoperative fasting is very important, because why? I will correlate now with the changes, because the pediatric baby, they can kids, they can easily desaturate. Okay, because not only they have decreased FRC, they have high oxygen consumption. Okay, and they can easily desaturate, and its respiratory causes, they cannot tolerate hypoxia, and they can have cardiac arrest. So it's a very quick happening. So if you are not able to handle this situation, because they will have anterior larynx, difficult ventilation, and so if you are not able to handle this situation, you can end up in big trouble. Okay, so this is with reference to airway management, and so pre-oxygenation is very important. In some cases, the baby will not allow you to have pre-oxygenation. Okay, but still, uh, as I told you, that if you have done a good preoperative anxiolysis by some way, now things can you can you will have a better chance of managing the things. But you should have proper sized equipment, and everything should be arranged pre-hand. Okay, so because I was telling you with reference to preoperative fasting. So it is 2, 4, 6, and 8 usually. So 2 hours, or even in some data they all even say 1 hour. So 1 hour or 1 to 2 hours for clear fluid, 4 hours for breastfeed, 6 hours for formula feed, and 8 hours if the baby is already weaned and baby is taking food. Okay, so it will be 2, 4, 6, 8 like that. And then another important thing, because now other physiological important thing is that because the airway is challenging, as I told you, sometimes some people will be using straight blade. So a straight blade may be used, okay? But again, I told you that the airway will be very fragile. The narrow point will be not you might pass through the vocal cord, but it will stuck at the because of the funnel shape of the airway in the pediatric age group. So it can stuck up in cricoid. Okay, so small narrowest part of the child airway is the cricoid cartilage. Okay, so the other next step is very important is that because the normal reflexes to the anesthetic medications and the responses, the autonomic reflexes are not developed. Okay, so the heart rate dependent cardiac output. So there is bradycardia, patient will not tolerate, and cardiac output cannot be maintained. So usually, practically also, the heart rate should be maintained around 100. According to, of course, according to the age, it will vary, but indifferently, you can say that you have to be very careful about the heart rate. So heart rate should not go down. So and also some old traditional anesthetists, they used to give atropine pre-hand. I don't think so. There is like compelling indication to definitely give atropine. But yes, you should be very careful about it. And of course, as I mentioned, that you have to calculate the doses according to the weight, because it's very critical to calculate everything. And actually, in good hospitals, the common emergency medications and the common medications, there is a printed chart which comes with every patient, that if you want to give epinephrine or atropine or what concentration it will be and how quickly you will give. Okay, so this is very important thing. With ref so Another thing which is important to rule out, if you when you are doing the preoperative assessment, one thing I have told you with reference to preoperative fasting, and I have told you the reason with reference to airway as well as cardiovascular, because cardiovascular system and respiratory system will go side by side. That's why I'm in making it in a combination. The other important thing is that there are some chances of congenital anomalies. Okay, so congenital anomalies, if you think, you should be thinking that the most dangerous anomaly for you will be the cardiac anomaly. Okay, because there is a fetal circulation which has some remnants which can there in the early life, or if the baby, if because of course not there will be two three different types of surgeries which you will be looking at. One surgeries will be the normal surgeries which any pediatric patient can have, like circumcision. Okay, you can have some tongue tie. Trauma can occur in any pediatric patient. Foreign body can be there. But in addition to that, the surgeries which will be there, the patient will be coming for some congenital anomaly. So you have to rule out other congenital anomalies. And the most important will be the cardiac one because of the fetal circulation. So you should have knowledge that what will be the like there may be presence of PDA, there may be some patent foramen ovale. Okay, so and of course any cyanotic or acyanotic heart disease. So in the preoperative evaluation, it's very important to rule out. So the thing which can give you an hint is does the baby become blue on crying? Does the baby landmarks are going fine? So these two, three questions will tell you a lot of information. If the baby is taking feed normally, not no bluish discoloration of the baby or sinuses upon crying, and the landmarks, the normal landmarks of the baby is fine. So this is just giving you a hint, not 100%. In certain conditions, you will need to have a check. Because these are the complex congenital anomalies, like in which there is a package deal, vector and vitral, if you are dealing with tracheoesophageal fistula or diaphragmatic hernia, things like that. Okay, so you always should be thinking about persistent fetal circulation. And with reference to PDA, you should be, if when you are doing the monitoring, or if you are dealing such case, the most reliable blood gas will be, or if you want to have arterial monitoring, it will be through right radial, because it will be pre-ductal. Okay, So this is also a baseline important point you should always know, because the right side arterial supply, the brachiocephalic trunk, comes out of aorta before PDA, okay, before ductus arteriosus. So this will be giving you the accurate one. So this is an also a point which is frequently asked in the even in the MCQs exam, or if you are answering any congenital anomaly in which there is some persistence of fetal circulation. Preductal right radial artery is the one. Okay, so you have to rule out congenital anomalies. Then another, I will just go further detail that what are the common congenital anomalies which are being asked in the exam. So one of them is infantile hypertrophic pyloric stenosis. Okay. One of them is congenital diaphragmatic hernia. One of them is tracheoesophageal fistula. Okay. And then they ask about Inna lillahi wa inna ilaihi rajiun. Other cyanotic heart disease. So with reference to the infantile hypertrophic pyloric stenosis and this abdominal wall defects. Okay. So abdominal wall defects, whether it is omphalocele or it is gastrochiasis. So there is a common pathway which you can follow, and you can crack any answer. The common things I will tell you first. All the common things which will be there will be prematurity. A number of such patients may be premature. Even if it is not premature, you have to rule out whether the baby is not premature. And then with reference to prematurity, another concept is with the post-conceptual age. Post-conceptual age. So you should be knowing this concept. I'm sorry, this is post-conceptual age, PCA. Okay, not patient control anesthesia. So, just a second. Okay. So, post conceptual is very important, because if it is less, some books will say 50, some books will 55, some books will say. So you can just roughly say between 15 to 50 to 60, there are more chances of apnea. Okay. So there are more chances of apnea. So any elective surgery will not be done before 60 weeks, usually. Okay. So like you have, if you have a patient with the circumcision, it's an elective procedure. You will not do in a premature baby unless it becomes 60 weeks. So this is also with reference to day surgery. So this is the important one. And if you have an emergency surgery, you will have an apnea alarm, an apnea monitoring. Okay. So there will be monitoring of apnea. So this is with reference. I'm just giving you, and again, I'm telling you that this is not the way written in the books, but I am integrating, because all of majority of the people who are listening to me at the moment, some of them are going for exam, and even the residents who are trying to grab this, this will be a good idea for you to learn how you should be targeting pediatric anesthesia, because I'm telling the best words and the important points which are important. Okay. So one of them will be the prematurity. You should be knowing, because there are certain details of prematurity, what are the systems involved, but usually the most important thing will be persistence of congenital the fetal circulation. This is one important thing with reference to prematurity. How severe is the prematurity? Like it is, I don't remember the exact duration, but you can see the classification of prematurity. So there is certain that it is that week to that week. This is cramming thing, so I have forgotten this thing. But important thing will be that if you are giving too much oxygen, it can cause oxygen toxicity. So with reference to retinopathy of prematurity and respiratory problem. Okay. So there will be atelectasis and oxygen toxicity in such babies if you give too much oxygen. So in these patients, try to use minimum FiO2. So this is another important point you should be thinking with reference to premature. Okay. On all other congenital anomalies, the approach will be the same. Rule out other congenital anomalies, rule out prematurity, anticipate postoperative apnea. Okay. and there will be sensitivity of anesthesia. Okay, because premature babies, their brain will not be like there will be so many changes which will be there in premature. Okay, so similarly, I will touch one by one these congenital anomalies. So to start with, for example, if it is infantile hypertrophic pyloric stenosis, so here come the question from where we started our discussion, which Iqra was asking about. The Ikra is still there or has left? Yes, you are here. So this is very important with reference to infantile hypertrophic pyloric stenosis, because the thing which will be there is dehydration. Okay, but the same concept of evaluation of dehydration you can use in any pediatric patient, and the same concept of pediatric fluid management you can use, which you are using here in all the patients, because here the potassium will be low, hydrogen will be low. Okay, because the patient is losing, the chloride is low, volume is low. Okay, and instead of uh, sodium is also low. Okay, so instead of, in the response of hydrogen is to conserve, because what is it is hyponatremic, hypocalemic, hypochloremic, metabolic alkalosis. So the next word is paradoxical aciduria. So because initially body will try to conserve sodium, body will try to conserve hydrogen. Okay, but when potassium levels will go critically low, then the response will be opposite, and body will try to conserve potassium at cost of hydrogen. So this is called as paradoxical acid urea. Okay, this is what is called as uh, which occurs in. So there is a hypokalemic, hyponatremic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Okay. So similarly, another important how to evaluate. So you have to evaluate the level of dehydration. Okay. So level of dehydration, because in adults, the cardiovascular responses will tell you there will be tachycardia, there will be hypotension. In pediatric patient, maybe these responses will not be very accurate. So the skin, mucous membranes, fontanelle, uh, irritability, conscious level, these are more important thing. So you will, first of all, you will evaluate whether it is like around 5%, 5 to 10%, okay, or more than 10%. So this is, I'm just giving you a rough idea. So usually it is 10 ml per percent dehydration. Okay, so per kg. So because there is a formula 4 to 1. So 4 to 1 formula is for first 10 kg, it's 4 ml per kg. The next 10 kg, it's 2 ml per kg. And for any weight after that, it is 1 ml per kg. So you will just assess the level of dehydration. So for example, if it is 10% dehydration and the body weight is 10 kg, so it is 10 multiplied by 10 multiplied by 10. So 10% for the dehydration, 10 kg is the weight, and 10 ml per kg weighs the for the dehydration. Okay, so it is will be around 1 liter, and but you will give slowly. So the answer is that you will be assessing the level of dehydration, and then you will have concern with the urine output. Okay, and gradually you can repeat with the venous blood gas or ABGs. Okay, and you will do the serial electrolytes. Okay, but generally you will start the fluid resuscitation. You will always have a look on the any signs of baby going in overload. Okay, and you will gradually give the fluid. The another important thing is that which fluid you should be using. The previously there was a terrible concept of using a PEDS solution, which is a terrible one of 10% dextrose water with 0.18% normal saline. It's a terrible, it's a killing solution. It's a killer. It's by, I am afraid it's still it's available in so many hospitals in the world. Okay, but it's a killer solution because hyponatremia is a killer. So never use it. There is no indication of PEDS solution. It's a terrible solution. Usually it is said that it's use isotonic fluids. So it may be ringer lactate or 0.9% normal saline, especially in this patient. Now the question is that with reference to dextrose. So there are so many ways of calculating. So you can give the resuscitation with isotonic fluids. For maintenance, you can use 5% dextrose water with 0.45% normal saline. This is one option. And if you have any premature baby, so you can titrate according to the blood sugar levels, and maybe you can give separately, like in a with one syringe pump separately, you can give dextrose water 10% if you want. Okay. So this is the journal principle. So you will assess the level of dehydration, you will calculate, and then according to the body weight, this is true for dehydration, and this is true for gastroenteritis, this is true for any obtunded baby cause of intestinal obstruction. Same principle will be occurring. Yes, there the pathology will be different in different problems. You will have a baby with volvulus. Okay, so all same principle will be there. Same pediatric anesthesia concern will be there. Same logistics, different size IV cannulas and different equipment and everything. And the most important thing will be dehydration. How to assess the dehydration, how to calculate the fluid, how much you need to give, and how will you. So there is a concept of goal directed fluid therapy. Okay. So like you will set some goals, you will see, but here you will it is more critical to, because if you give too much fluid, baby can go in overload. So and I, because I don't do here in our like in Saudi Arabia, there are specific pediatric anesthesia, so we hardly, especially in the centers where there are assigned designated pediatric anesthetists, so no one else is doing these cases. But whatever experience I have, I'm just sharing with you. I didn't use cardiac output monitors in pediatrics, so unfortunately, I don't have anyone working in a children hospital can tell you in details. But I'm just telling you that you will be looking at the output, that like when the baby is passing the urine, or if the baby there is, it's not intubate, this Foley's is not there. It's better to pass the Foley's. Otherwise, baby nappy wetting will tell you. Another important point with reference to this hypertrophic pyloric stenosis is that it's not a surgical emergency, it's a medical emergency. You will rehydrate the baby when the urine output will start coming, electrolytes are corrected, only then you will go for surgery. And usually they are doing the myomectomy, this what forgot the name of the procedure. They do the myomectomy. They open the this pylorus. Okay, so another important thing is that this baby will be at risk of aspiration. Okay, so you will find in the books four quadrants in four position. So you will be doing the NG sectioning from the like stomach in four different quadrants. I have not done it ever, but it is written in the book. So I'm just telling you what I can recall. So these are important points. And again, I'm repeating the common things: physiological, pharmacological, anatomical consideration will be the same. Difficult IV will be the same. Consent issue will be the same. Difficulty in communicating with the baby and rapport building will be the same. Okay. Then IV lines and if everything fail, I forgot to tell at that time. If you are not able to find IV line everywhere, then the last resort will be intraosseous line. Okay. So you should be knowing about the intraosseous line system, which I mentioned. And at the same time, I forgot one more thing. I'm just, whatever I'm recalling, I'm telling you that temperature, because the homeostatic condition are very important to maintain. So one of them is oxygen, one of them homeostatic condition, I'm telling you. CO2, temperature, okay, volume. This is for any patient, by the way. This is, you should be thinking every patient. Then acid base balance, fluid balance, and electrolyte balance. This is the called as homeostatic condition. So in babies, because usually the shivering mechanism is not there and they are dependent on brown fat. Okay. And this is more so, this will be more so in a premature. So you have to be very careful about it. Okay. So environment, theater environment should be warm, fluid warmer should be there, warming blanket should be there, so that the baby does not get, because if the baby become hypothermic, it will result in delayed recovery. It can cause a lot of problems. Okay, so this is with reference to uh, like some of the, we have almost covered all the physiological changes. Yeah, with reference to renal and liver, I tell you that it's not fully developed. So up to 2 years of age, kidneys and nephrons are not working to the maximum, but after 2 years they are working in like an adult. If I'm not wrong, just because these are theoretical things, sometimes it slips out of the mind. So, but you generally should be knowing when the changes become to the near to the adult. This is also something you should be knowing, when the kidneys become like adult, when the liver become like adult, when the respiratory function. So you will find in the physiological changes portion, you will find this. But I'm just telling you. So this is an important thing. Another problem will be how to put with reference to monitoring. We missed few things. I'm just telling you before going into tracheoesophageal fistula and congenital diaphragmatic hernia. I will just try to tell as many things as possible. Pediatric analgesia we will also discuss. So with reference to monitoring, what will the challenges that normal pulse oximeter will not work in majority of cases. So you should need another, which is another different Massimo and different companies, which will be sticking to the patient with the like a tape. So it's a different sort of pulse oximeter. Okay, so pulse oximeter will be you should be worried about it. Then another important thing is that when they are doing end-tidal, should be after three failed cannulation. Thanks a lot, Sharjil, for a tap of 90 seconds of trying to secure cannula. Thanks a lot. Yes, but actually, because you are working in UK, so the things dynamics are a little different. In my eight, I will be very afraid to share this thing. I have never done intraosseous line. I never get a chance to do it. So, of course, if you have the facilities and if the system is like that, of course, you should not poke the baby throughout the body. Yes, you are absolutely right. So, thanks for adding this point. Dr. Sharjeel is working in UK. Thanks a lot for adding. Okay. So, with reference to anti-idle, usually there is mainstream and side stream monitoring. So, mainstream monitoring will be like it can create problem because it can make the circuit very heavy, and because it's very important to fix the endotracheal tube nicely, because it can easily dislodge, number one, and it can easily displace. It can easily come out, or it can easily go inside, like it can become endobronchial or it can come out. So you have to be very accurate in fixation, and if you are making the circuit very heavy by mainstream, because anti-idle CO2, they are two different. One is side stream, usually they are using side stream, but again there is another problem with side stream, that dead space will be increased. And another thing is that, like, you should be very careful about, because both have their own pros and cons. So with reference to end-tidal CO2, with reference to arterial line, I told you the preductal and urine output temperature. Yes, temperature monitoring, either it can be done with the, because we need the core body temperature. So usually rectal temperature is because rectal is giving a little higher, but is relatively more accurate, because in babies, if you are putting in oral, sometimes it's not giving you a very accurate, because of the non-availability of the specific. Just a second, please. Another comment. Emergencies only, of course. For active one, may consider using ultrasound and seek senior help. Thanks, Sharjil. So these were the few points which I will. So I will, because we are getting short of time. I'm afraid I will not be able to finish all the diseases. But let's discuss some points with reference to tracheoesophageal fistula, because tracheoesophageal fistula, again, you have to rule out vectoral and veter. You can because this is a combination of congenital anomalies which are coming together. So this is the this vertebral anomalies and cardiac anomalies. And can anyone of the exam candidate just remind what is vectral and what is lateral? This is V for vertebral anomalies, aplasia, renal aplasia. This is for renal aplasia. This is for esophageal atresia. This is for tracheoesophageal fistula.
Imperforate anus, sir.
Imperforate anus. Okay. So this is for, so actually it will be depending on the type of tracheoesophageal fistula, but usually there are different techniques of intubating such patient. But some people will go deep, and then they will be keeping out auscultating, and where they will see the gush in the stomach, they will just push further deep. So the communication, they have to bypass. The general rule is that the communication where it is, you have to bypass the tube and go further deep, so that the air which you are like when you are ventilating, it should not go to the stomach. Okay. So I again repeat, there are different, some people will be using fiber optic, some but usually the normal way will be to go endobronchial, and then you will keep on withdrawing, and the place where you see that there is air going also in the stomach, you will see here, listen to the sound, and you will go further deep, go back. So this will be a rough idea that you have bypassed that area. Another important point with the reference, that when you are inducing, it is better not to have positive pressure ventilation, uh, because if you are doing positive pressure ventilation, it to the start with, air will go inside the stomach, and there will be problem in the ventilation. Some people will put NG tube simultaneously, so it will be deflating the stomach. But just I'm telling you that usually it is recommended not only in tracheoesophageal fistula, also in congenital diaphragmatic hernia. It's not recommended to give too much positive, because in congenital diaphragmatic hernia also, usually the surgery will not be done unless, usually because congenital diaphragmatic hernia, the baby might go in the ECMO. They let the development of the lung. Okay, because if they try to correct it before that, the outcome will not be good. So sometimes they will let the with all the steroid and surfactant, they will try to get the lungs developed, and then they will go for surgery. Okay. And in all though both, there will be chances of aspiration, there will be chances of pneumonias. Okay. So because there is communication between the airway and the gastric system. Okay. So in addition to the all normal concerns, these are the main points which you need. How to, what are different types, what are the communication, they will ask you how to rule out. So you should be telling that there is association with this mnemonic. So you will rule out everything. Okay. Positive pressure ventilation, and how will you intubate. These are 2 3 important points which you will never miss. Rest of the things are will be the same, because in the last 5 to 10 minutes I will try to give some points about the analgesia, pediatric analgesia. So we are actually short of time. Okay, so congenital diaphragmatic hernia, almost the same techniques and same thing. You don't have to give too much positive pressure ventilation. And if suddenly there is a MCQ which is coming and again, that suddenly if there is increased airway pressures suddenly and patient is desaturating, that might be there is a pneumothorax has been developed. So this is an important point. As I mentioned, this is all 3 of them are medical emergency, not surgical emergency. Okay, so you will let the patient come out of dehydration in pyloric stenosis, and let the lungs develop before going for the surgery. Okay, so okay, so another few of the diseases, another disease which can be asked is Down syndrome. So Down syndrome, all other concerns will be the same, even cardiac. these babies, they are at risk of epilepsy, airway challenging. Okay, where not only the trachea is small, there is chances of atlantoaxial subluxation. Okay, and then in addition to that, there are chances of hypothyroidism. Okay, and so you have to be careful with these babies. Down syndrome, cardiac anomalies can be there, chances of epilepsy, and if the buzzword will be that patient may be taking anti-epileptic medications. Okay, airway will be challenging, atlantoaxial subluxation, hypothyroidism. So with reference to abdominal wall defects, okay, the important points is that either it is gastrochiasis or omphalocele. So there will be a lot of dehydration. Okay, this is one important thing. Direct abdominal injury can occur. So perforation even before the patient is going for surgery. Then another important point in this surgery is that sometimes they are doing staged surgery, not in one go. They are doing the surgery. They are doing in repeated sessions. But again, as we have already discussed, the common concerns are the same in any pediatric. So you just need to know three or four important points about each of the condition. Okay. So either it is gastrochiasis or omphalocele. So this is another thing. Then let us discuss some points about the analgesia. Okay, so actually, usually, paracetamol is one of option. Either it is given preoperatively, or it there are suppositories. Okay, or you can even give 10 to 15 milligram per kg of IV. Okay, so this is one option, either in the form of suppository or IV. Then diclofenac sodium, some people will have some concern in the younger population. Maybe people will not be using much of this diclofenac sodium, but again there are available of suppositories of diclofenac. Okay, then regional in certain common procedures, like you can have penile block for and this one this circumcision. Okay, caudal block, very important. Caudal in any surgery below the level of umbilicus in pediatrics you can use. There is a specific Armitage regime. The important thing, remember one thing, that you should never cross the maximum dose, 2 milligram per kg. This is one important thing with reference to even Armitage regime. Another thing is that concentration. If, for example, if you have a 5 kg baby and you want to give a little higher up, it will not be a sole anesthetic agent. Of course, it will be just for analgesia. So usually it is 0.25%, but if it is with 0.25, it is 2.5 milligram per ml. So if it is crossing the safe dose, you will decrease the concentration. Okay, so you will not go beyond the safe dose. Okay, so with reference to caudal anesthesia, this is very important thing. Then you can give the people who are doing laparoscopic surgery, they are giving tab block in pediatric. Again, the problem will be the volume. I have never done like tab block in pediatric patient, so I cannot recall how much volume they can give. But with reference to opioids, uh, morphine problem, it's not contraindicated to use morphine uh, unless there is prematurity and there are chances of apnea. But in certain surgeries, in day surgery, it's not advisable to use morphine because it can cause delayed respiratory depression. Okay, this is another important point. Uh, Okay, so few words about the rest of the medic people, they are using even Presidex, dexmedetomidine, as I told you, ketamine. Okay, and multimodal analgesia will be the approach with paracetamol, diclofenac, opioids, non-opioids, dexmedetomidine, ketamine. Okay, and along with wherever possible the regional blocks. Okay. There are certain surgeries which are common, as we have already mentioned some of them. Circumcision is one of them. Okay. Then another very important is adenotonsillectomy. Okay, this is a very common surgery in pediatrics. So in adenotonsillectomy, remember that there will be chances of bleeding. Okay, this is one important point. Other point is shared airway. Tube can kink, tube with the bowel, they have a mouth gag, and the problems can occur. Okay, and these patients with the adenotonsillectomy, they sometimes they have OSA. So you have to roll out OSA. Okay, usually OSA will improve, by the way, unless it's so severe that it is causing pulmonary hypertension or things like that. Usually, OSA, like if the surgery is adenotonsillectomy, actually what happened that after the surgery, because the obstruction has been removed, so actually the symptoms improve. Okay, so this is another important point. This question is frequently asked with reference to post-operative bleeding, adenotonsillectomy. Okay, so again, the same points which I've discussed, that it is difficult to assess the dehydration or volume status in pediatric because the normal cardiovascular responses which are there in any other patient, in adult, it will not be there. Okay, so the dehydration, the same principles will be there. Okay, and serial and another here, usually if there is bleeding, you can assess how much bleeding has been done. But here, unfortunately, because the baby is inhaling, the just like it's going inside the stomach. So exactly how much bleeding has been occurred, you cannot assess. Okay, so you clinical judgment as well as with the labs. So and patient will be having another anesthesia. So patient you will be considering as full stomach and rapid sequence induction. So this is another actually important topic, but I'm just trying to tell another important thing which I actually was just it was just touching my mind was in it will come back. I forgot actually what I was telling. Uh, yes, respiratory tract infection. Okay, RTI in so when which respiratory tract infection will lead to cancellation of the case? So actually, usually, not all respiratory tract infections, like if minor sneezing, it's not. There is a criteria we should be knowing that unless it is with purulent sputum, wheezing, productive cough, okay, fever, only then you will cancel for 4 to 6 weeks. Otherwise, simple normal sneezing, it's not the uh, reason to cancel. Okay. And another thing, it's very difficult to get a window of total infection free, especially with reference to this adenotonsillectomy, because they will not do in acute inflammation because it will cause too much bleeding. Otherwise, they can proceed it. And the child coming with for any other procedure with respiratory tract infection, it's always a debatable topic. But the documented indications is the one which I have told you. Not all respiratory tract infection, apparent minor cough or mild sneezing is not the reason for cancellation of the case. Okay. So this is another important point. And certain diseases you should be knowing. One of them is cerebral palsy. Okay. These patients come for some because this will be a bedridden baby at not taking too much. So same problems can occur. They are coming for PEC tube, okay, or gastrostomy tube, and so you should be. They can ask you about the different types. There is one spastic and one plegic, okay, and the severity will be different. uh, some of the common things will be the same. So actually it was very difficult to give you a concise because pediatric anesthesia is such a big topic. Okay, I have just tried to give you an overview. Okay, and you can just ask any question if you want, please. Any questions, please, because I have to finish in next few minutes. Sharjeel, please, can you add on some things which I have missed? Dr. Sharjeel Chaudhary, it's an honor for me for you to be here. Ikra, anyone wants to ask any question, please? I will share some data with reference to.
Sir,
Yes,
hello.
yes, please.
Sir, can you hear me?
Yes, I can hear you.
Sir, can you please repeat in how much duration we have to replace fluids in a dehydrated child? The maintenance one calculated by 4 to 1 rule regarding
Yes.
per hour maintenance fluid. Do we have to add this fluid calculated by the percentage of dehydration in this maintenance fluid, or kindly please repeat? I
No, actually,
can't understand the.
actually with dehydration, it is a little different because this is for maintenance. Like for example, if you have a 10 kg, so what is the maintenance? It is 40 ml per kg. Okay. And the formula or the calculation which I told was for dehydration. If the baby is more than 10% dehydrated, so if you are taking for 10, so it is 10 ml per kg per person dehydration. So it is 10 into 10 into 10. So this is 1 liter. And you will be giving over period of say not immediately you will give 1 liter fluid. Okay, you will keep on giving the fluid, maybe initial 8 hours or initial 6 hours, and then gradually there is no fixed rule for it. Okay, so 40 ml per kg is the maintenance. And usually when we are managing such patient, actually what we do, we are giving dextrose saline for the maintenance and isotonic fluid for the resuscitation. I hope you understand.
Okay, sir. Thank you. Thank you,
Okay,
sir.
so I have just given another important things which you will find: cleft palate, cleft lip. So these patient will have problem in ventilation, and the rest of the things are the same. You just have to rule out other congenital anomalies, and uh, you will have problem with ventilation, and you will have problem with intubation. Okay, especially if it is cleft palate as well. Cleft lip will not create too much problem, but even in cleft lip you can have problem in sealing the airway and ventilating the patient. So rest of the things are the same, but you should be knowing, because this question can also be asked. Pediatric urological procedures, they are doing hypospadias. Usually they are fine babies, but again, I will use the same word, that you have to rule out other congenital anomalies, and the same principle will be there: altered physiological, pharmacological, anatomical considerations, and all the logistics which I have discussed in the start: preoperative endolysis, preoperative IV cannulation, um, repo building, like the calculating the doses, selecting the proper equipment. Okay, so these are the things which you should be knowing. Okay, I'm just having a look on the topics which are surgeries. One of them I told you, this urological surgery, hernia. Okay, hernia. A number of times they are coming for herniatomy. If the patient has sickle cell disease, okay, so in sickle cell disease, sometime in pediatric age group, they are coming for cholecystectomy. Okay, so this is one of the surgeries. Usually a baby will never come for cholecystectomy. So in pediatric patient with certain diseases, you will find these surgeries. Okay. Yes, very important. Actually, I'm really sorry that I don't have time, but I have discussed in detail foreign body. So please just have a look on the YouTube link. You will find foreign body is very important. It's very important how will you managing this case, assessment, where is the airway, where is the what type of foreign body it is, and possible location if it is radio opaque and you are able to find where it is. Usual basic principle is that you will not try to poke the patient, and because if the baby will cry more, even it can go further deep. Okay, so there are certain techniques for it, but usually inhalational induction, and even you will be ready for tracheostomy, and all the emergency uh, maneuvers should be there. Okay, and usually inhalational induction, then maybe you can see through the surgeon can have the rigid bronchoscope to locate the foreign body. You can ventilate in between. So there, actually, this is a unfortunately, it needs a lot of time for me to explain how to deal this case. Okay, so that's it. So, like, if any point is missed, you all are welcome to ask. Okay, and as I showed you this playlist, you will find, because I have done at least a lot of sessions on pediatric anesthesia. So I will highly recommend all of you to have a look on this playlist. Okay. I have discussed in detail all the topics separately: tracheostomy, fistula, upper airway obstruction. Okay. This was with this laryngotracheal bronchitis, Strider, crew. Okay. So we have discussed all these topics: cerebral palsy, emergence delirium, scoliosis. So bleeding tonsil, I have done a number of times. One of the session was conducted by our doctor from Ireland. Okay, and thanks a lot, all of you. Tomorrow, most probably, we will try to do obstetric anesthesia. Okay, so thanks a lot, all of you. If please I have missed anything, just feel free to ask any question. I was actually today I was a bit rusty. I was a bit sleepy, but because I want to just give you all of you a quick revision. So as before finish, I will just drop my number. All of you are welcome to ask any question to me anytime. Okay. So thanks a lot, all of you. And thanks, Shirjil, for joining us and honoring us. Assalamu alaikum.